Great. Good morning, everyone. I'm going to go ahead and get us started. First of all, welcome back to Grand Rounds, Surgical Grand Rounds. COVID's been rough on everyone and on in-person attendance, but I think we can come out of the COVID phase. I know there are a whole bunch of people that are joining online, and I would like to bring this event back in person as much as possible. So, any resident, fellow, faculty member that is here in the hospital should come in person rather than using the Zoom link. And Dr. McIntyre, who's not here today, he's actually on vacation, and I will kind of sort out some methodology just to revamp in-person attendance. Those of you off campus, obviously if you're operating somewhere else or seeing a patient, even at Children's Hospital, I think it can be a hardship to get back and forth because it's a 20-minute walk. Of course, we will provide a Zoom link for you to participate. All right, to get on with this morning's program, I've introduced Dr. Jaiswal to you multiple times before. She's an associate professor of surgery in the Surgical Oncology Division. She did her undergraduate training at SMU and then went on to medical school as well as general surgery training at UT Southwestern, and then did a surgical oncology fellowship at the NCI, stayed on clinical staff there, I think for about 2 years, and then went to Memorial Sloan Kettering to do a breast oncology fellowship. She then went to Denver Health to really lead and build the breast oncology program. And more recently, she has taken up more education roles and serves as the GME director for well-being at the School of Medicine. So this is all School of Medicine programs. She is an associate program director in our general surgery residency. And I think the trainees and many of the faculty will recognize some of the key programs that she has led and co-led and helped to put in place. And those are the coaching programs for our residents, the holistic review process, which has been a game changer in our classes coming in, as well as well-being programs. She's also the clinical content director for the medical students in surgical education. She publishes both, as you might expect, in education and in oncology. And she has really helped our department to flourish in multiple spaces, but especially in the education space. This morning, I think some of you know more about this and others may actually know a little about this. But she will overview Entrustable professional activities and why we're doing it, how we're doing it, and what kind of difference it will make. So with that, I invite you up to the podium. Thank you.
Thank you, Dr. Schulich, and thank you all for giving me the privilege of this podium and your attention for the next 45 minutes or so. And while this talk is going to focus a lot on the general surgery residency training programs, I would encourage all of my colleagues in other subspecialties, especially thoracic and vascular surgery, to also pay some attention because those specialty boards are also working on bringing EPAs to those training programs as well. And I think, honestly, that over time, this is the wave of the future. I suspect that this will continue to make its way through many, many GME programs. So I have nothing to disclose pertinent to this talk other than that I'm a volunteer for the American Board of Surgery EPA writing group, and I'm part of their speakers bureau. So many of these slides were specifically curated by the American Board of Surgery for the purposes of creating a uniform Grand Rounds presentation for use across the entire country. What I hope to cover today is the why, the what, the how, and so what of EPAs. Why are we doing this? What is an EPA? And how will we go about implementing it? And what is the significance to our end users, our residents, and our faculty? So, of course, the EPA in this talk is not the Environmental Protection Agency. But before I dig into this nitty-gritty, I want to step back in time 22 years ago. It's not lost on me that I'm presenting to you today on the 22nd anniversary of the 9/11 attacks. I'm sure many of us remember the exact spot we were in when we saw these terrible events unfold. I recall being a second-year general surgery resident at Parkland Memorial Hospital in Dallas, Texas. It was a Tuesday, a pre-call day for me, and I was in the OR in the middle of our first case doing an inguinal hernia with my chief resident. A nurse came in to tell us that the rest of the day's elective cases had been canceled. No other explanation was provided. And so, of course, being an eager second-year resident, at the end of the case, I stomped back out to the front desk to try to figure out who had canceled my wonderful elective case day and try to figure out how I could get them back on the board. Of course, everything was explained when I looked at the big screen TV in the OR lounge, that those cases weren't going to happen that day. When I look back at my residency training during that time, there's a couple other things I remember. The flip phone and the pager were items that were cool. And residents actually did really run Parkland Hospital. Attending sightings in clinic were rare, and attendings only occasionally scrubbed in. And that meant that the case wasn't going so well. I remember that 80% of what I learned in my training program, I learned from my senior residents. And when our program director asked us to keep time cards to see how much we were working during that my second year of training, I thought, oh gosh, this is an easy week. And I realized it was 109 hours that week. And that's when I first thought, oh gosh, there are 168 hours in the week. I was also told by many attendings that my colleagues and I were not going to be fantastic surgeons because we were no longer required to take every other night call. I also learned that the good residents learned how to so-called fly under the radar. No feedback meant that you were doing well. And written evaluations occasionally showed up in our physical resident mailbox with a handwritten note. Good job, read more. In contrast, 22 years forward in 2023, our residents are geo-tracked using their smartphones to assure that they work less than 80 hours per week on average. Most pagers have disappeared. Attendings have their own clinics and they scrub on most cases. Residents are actually asked their opinion on an annual survey, and good marks on that survey are required for our program to undergo continued accreditation. Residents actually want feedback. And only 73% of residents are satisfied with the feedback that they do get. So essentially now, residents are facing a rapidly increasing body of knowledge that they're required to master. And they have 30% less time in the clinical space with which to do this. Additionally, a bunch of our young trainees are faced with the downstream effects of being removed from the clinical spaces during COVID and the subsequent case cancellations, thus decreasing their clinical exposure even more. However, the time-limited aspect of training remains the same. It's still 5 years. So to think about this a different way, our current system offers one pathway to surgical training. You spend 5 years, you're the surgeon at the end of it. But because individuals acquire knowledge, skills, and abilities at different rates, at the end of this period of time, probably not everyone has reached that desired developmental competency outcome that we want. So our fixed time system has resulted in variable outcomes. And as some of you in the audience will know, the consistency of our training product has been called into question in the last decade by fellowship program directors, by the lay press, and by our trainees themselves when surveyed regarding their confidence of entering practice. Many of you will remember the study in the upper left-hand corner, which suggested that nearly a third of graduates entering fellowship could not complete a laparoscopic cholecystectomy independently or make progress over a 30-minute interval on a challenging case. So imagine instead of a time-limited system, what if our ideal system could look like this? where we first define what is required to become a surgeon and to ensure that all of our graduates are competent to perform these minimum requirements before they head into practice. We focus on and fix the outcomes at the end of training and instead allow flexibility in the time necessary to reach that endpoint, thereby ensuring that the same level of competence is achieved by all of the trainees at the end. So why EPAs? There are a number of reasons that the American Board of Surgery thinks that this strategy is robust in its ability to address the issues that are facing our learners and our faculty today. And I'm going to review each of these in the next couple of slides, but briefly, the ABS believes that EPAs enhance feedback, which is critical as the learner progresses in a limited amount of time that they have. EPAs respond to the competency mandate foreseen by our predecessors. EPAs model the public trust that's fundamental to our educational model. And the EPAs create a relatable framework. And I'll show you the words exactly that are used, and they are very day-to-day words, not esoteric educational words. EPAs leverage assessment as a driver of learning as well. So first, let's start with the feedback. In 2009, a Canadian orthopedics program implemented an EPA-based clinical assessment model that found that formal feedback to the trainee increased 5-fold compared to their traditional model. And as such, 2/3 of the trainees were ready to complete their training ahead of schedule. If you look at the website for the Royal College of Physicians and Surgeons of Canada, you'll see that they're transitioning nearly all of their GME programs to an EPA-driven, competency-based training program. And of course, we know that more feedback for the trainees is something that all of our learners would like. And EPAs provide an opportunity to provide timely, in-the-moment, actionable feedback directly in proximity to the time that a particular performance was observed. Another reason for EPAs is the mandate to move towards a competency-based rather than time-based model of education. And this was called for back in 2002 when the Blue Ribbon Panel convened. The Blue Ribbon Panel consisted of a variety of educational groups throughout the US. This group called for a standardized national curriculum, which is now known as our SCORE curriculum, as well as a strategy to verify competence at each level. EPAs are that mechanism to verify competence. So in fact, when we look at the 5 core components of competency, having an outcome framework is the first bullet point. EPAs define that desired outcome of what we want our trainees to be able to do when they're done. So why competency-based medical education? This move to competency-based medical education has been gathering steam for 70+ years. But in the last 25 years is really when it's been taking the medical education groups by storm. And as such, the first movement of this is the first substantive reform in surgical medical education that we've encountered since the era of Halsted and Flexner back shown on the far left. An educator often seen to be a father of the movement of competency-based medical education is Ralph Tyler. He was an influential American educator who emphasized the need for learning, not just to be focused on cognitive objectives, but what can one actually do? Not just knowledge acquisition, which we test by multiple choice exams, but actual knowledge application. Another reason for EPAs as a component of competency-based framework is the importance of our stewardship to the public trust. The public trusts us to make sure that our graduates are safe and competent. How do we steward that responsibility to the public? How does Dr. Naylor know it's okay to sign at the end of 5 years, 5 to 7 years, that this person is ready and safe to be out in public? So EPAs an trustable professional activity, provide that framework by which Dr. Naylor will be very sure that when we graduate our residents, we will have a consistent and safe end product. So an additional reason EPAs are of value is their relatability to residents and faculty in just a normal daily workflow. When we think about the ACGME 6 areas of competency, it's pretty easy to evaluate competence in medical knowledge and patient care. We see that in front of us every day, we do it, and that's easy. But things become a little bit more complicated when, it's not advancing. Things become a little bit more complicated when assessing interpersonal communication skills and professionalism. And even worse still, when we're trying to figure out how to describe a resident's systems-based practice or practice-based learning and improvement skills over the last month at the end of the rotation. A further part of the why is the importance of assessment. In business, we might say that what gets measured is what gets done. In education, assessment defines whether the goals of education are being met. And this helps orient the efforts of both the resident and the teacher. Without a meaningful clinical assessment model, we're sort of bowling without pins. We're not sure what we're aiming for. Another reason EPAs are important is the concept of entrustment is founded upon the base character qualities of what it means to be a true professional. This was illustrated by Ali Tenkate, who is the originator of EPAs, highlighting the character foundations on which entrustment is based. So in order to trust somebody to do something, they have to be reliable, they have to have integrity, they have to be capable and have humility. Those are the basic tenets of being a professional. Finally, EPAs focus our assessment not in a simulation lab or on a multiple choice exam, though those have their place in medical education. EPAs help us move from a focus on knowledge and skill acquisition to actual skill and knowledge application. They do this by focusing the assessment in real time on everyday workplace assessments and activities that the surgeon is doing. Educational reformers like Donald shown here, have highlighted that the workplace is where a profession is executed. And in our case, that's the bedside, that's the operating room. Schoen highlights that this is where we can teach and develop our trainees to become independent practitioners. So I now want to move from the why to the what. What is an EPA if it's not the Environmental Protection Agency? So an EPA is an essential task of the discipline of surgery that someone can perform independently in a specific context. Accordingly, a set of EPAs can define the core of a specialty. They allow us, again, to move the focus of assessment from abstract or segregated competencies to something that's more practical, something that can be witnessed and observed on a day-to-day basis. So an EPA is important in integrating all of these different discrete competencies under one single rubric. So for example, to take care of a patient with breast cancer, a trainee needs to not only have medical knowledge, operative skills, but they also need to know how to communicate treatment options and lead a discussion using shared decision-making. The single breast EPA brings all of those components together to answer the question, can I trust this resident to take care of a patient with a breast problem? The EPAs were defined by a scoping council under the leadership of Dr. George Sorosi, depicted here. These were defined as the core activities of a general surgeon. So the floor of the specialty, not the ceiling, but the floor. Certainly many training programs and many trainees will be doing more advanced cases and more advanced topics than shown here. But this is the floor of our specialty. So these were created using currently available national data on resident logs and practicing physician case logs as well. And the ABS believes that these activities can be meaningfully assessed in all training programs, community programs, academic programs, and others. So Dr. Bernessa Lindemann has captured these EPAs in a graphic, with the first 5 that were studied in an initial pilot study are shown in the gray background. And as you can see, this list covers most of the things that a general surgeon would be asked to do in practice. This work has obviously involved a lot of work, a lot of online and in-person work and expense, as well as ongoing collaborations with key stakeholders. Literally thousands of hours and millions of dollars have gone into this effort and are continuing to go into this effort, all with the goal of improving the standardized quality of our training program and the end product. The steps in developing an EPA include first, defining the functions expected of a competent provider. What do we expect a competent general surgeon? How should they function? Second, we map these to our other existing competency models, specifically the milestones. So the milestones are not going away. And 3, we define observable behaviors that would be exhibited at the various levels of entrustment on the pathway to being practice ready. So here's an example of the functions document for the gallbladder EPA. As you can see, there are preoperative functions that include workup, diagnosis, informed consent, risk assessment. And then there are also intraoperative components, such as identifying the critical view of safety or being able to perform cholangiography. And also postoperative elements, including managing complications. And so all of these together are all of the functions of a single EPA. Then the functions are mapped to milestones. Here's a partial map of the EPAs and how they relate to the milestones. For example, the gallbladder EPA hits all of the patient care milestones, as well as medical knowledge 1, systems-based practice 3, communication skills 1. So that's the view under the hood. And I show you this not so that you can memorize this, but just so you can see how the EPAs will work with the milestones. And it's important to know that on the ground faculty, you in the clinic, you in the operating room, are not going to need to worry about this graph at all. On the other hand, program leadership, our clinical competency committees, the ACGME, the RRC, the American Board of Surgery are going to use these sort of under the hood data to make more summative performance decisions of a trainee to see if they're on track, to see if they're able to be promoted to the next year. The milestones for any given EPA will occur in the different phases of care. So preoperative, intra-op, and post-op. And here's sort of a graphic depiction of where some of these milestones fit in the various phases. Clearly in the preoperative phase, we have diagnosis and pathophysiology, and intraoperative, we clearly have PC3, which is technical skills and systems-based practice. And of course, in post-op phase, we have PC4, which obviously includes post-op care, as well as systems-based practice too. So again, all of that is under the hood. What frontline faculty are going to see on the app shown here is actually just the behaviors. And these behaviors are shown here in the bullet points. So across the top is the phases of care, pre-op, intra-op, and post-op. And along the left-hand side that are in those colored boxes are the levels of entrustment. And these behaviors then are mapped, you'll see in parentheses, they're mapped to the specific milestones. I'll go into a little bit more detail here. So what are those levels of entrustment? So there are 4 to choose from. 1 is limited participation, direct supervision, indirect supervision, or practice ready. So let's go through the intraoperative phase of a gallbladder EPA with these different levels of entrustment. The way you want to think about this is if I were to do the same exact case with this resident tomorrow, I would grant X level of entrustment because I observed them doing these particular behaviors today. So for example, for a learner who can articulate the critical view of safety, but they struggle to actually find it in the operating room, that resident is probably at the level of direct supervision. The learner might still be figuring out how to use both hands in a coordinated way, and maybe they're tentative with the instruments, but maybe they can remove the gallbladder from the liver bed with minimal assistance. So in contrast, somebody who is practice ready can perform the whole cholecystectomy plus minus cholangiogram in all patients, and they can recognize and deal with complications. They've got smooth movements, but maybe they lack economy of motion during the more difficult situations. So to reiterate an important tenet of EPAs, the assessment of what level of entrustment you would give a trainee is what you would grant them next time based on the performance that you just witnessed today. So those are all of the details. Now, looking at all of the 18 EPAs, I wanted to show you where there are some common themes among the EPAs. So themes are woven into the framework of EPAs where they best fit in the clinical context. So colon disease and trauma EPAs have behaviors written into them that hit the topic of patient safety. Not that patient safety isn't important in all of the other EPAs, just that the behaviors that we think are observable may occur most frequently during the evaluation and management of colon disease and trauma. Even some of the harder to observe components of competency have been able to be incorporated in appropriate contexts, such as self-care awareness when engaged in the demands of taking care of a critically ill patient. So in summary, this part of the talk has been the what phase of this presentation. So hopefully you understand what EPAs are, and now the question is, how in the world are we actually going to do this? The ABS has been working on this question for several years. From 2018 to 22, the ABS coordinated a pilot study of 5 EPAs at a set of 28 programs across the country. These programs were from various sites as well as various types, academic, community, and the like. The results of the pilot study show that over 100 residents were available for assessment during that time. And during that time, over 6,000 micro assessments were collected. And of note, while surgical faculty filled out 85% of the assessments, there was a fair number of 13.8% of non-surgical faculty that also filled out EPAs. And this was often due to emergency medicine faculty providing EPAs on consultation and trauma resuscitation, depending upon the clinical setting. So in the pilot, the number of residents available for assessment made up about 10% of the US general surgery resident population at the time. In the latter 2 6-month cycles of this 2-year pilot, those were impacted by COVID, and there were fewer residents assessed during those timeframes. And in this pilot study, a lot was learned about what is best practice. What is best practice that promotes completion of these EPAs, with the leading program completed over 1,000 assessments in less than 2 years' time. Conversely, there were programs that did not collect a single assessment at all. So the ABS has been looking at why are there those differences? What made program number 6 collect 1,000 plus assessments, and what made program 2 and 17 collect none? The highest performing programs, one of the features of their success is that they had tremendous support from the chair and the program director, as depicted by Dr. Minter and Dr. Greenberg from the University of Wisconsin program here. And even in that context, they demonstrated peaks and valleys of engagement and utilization based on faculty and resident development and assessment cycles. For example, a major drift occurred after the initial faculty and resident development push, and a major upswing was noted when the new interns started the following year. One of the key lessons from the pilot was that data collection worked best at sites that used a mobile app rather than a piece of paper, of course. The ABS has accordingly contracted with the Simple Collaborative to provide this EPA app that hopefully most of you have. The Simple Collaborative will be responsible for data collection and also responsible for giving us user-specific dashboards so that all programs can use the data to make progress. All of this cost, all of the Simple Collaborative costs, the development of the EPAs, the development of the app, all of that cost was borne by the American Board of Surgery and continues to be. So these are the general assessment elements that are included in an EPA microassessment. An assessor will be able to open the app on their phone, choose a trainee being assessed, and the specific EPA being assessed. You then choose the level of complexity of the case that you just worked on or the type of patient that you took care of, and then choose an appropriate level of entrustment that you would grant the next time that you worked with a resident based on what you just witnessed today. Based on the pilot experience, it takes about 1 to 2 minutes to complete, and they can be initiated by an attending or prompted by a resident through a notification function. To ensure the validity, the assessments will be open within 72 hours of an opportunity to assess based on prior studies. So once done, all of this data will be part of a secured database, and this database will populate dashboards that we can use for making progress. So to wrap up our discussion, I wanted to talk about, well, so what that we are going to be moving towards EPAs. How will programs practically use these assessments and find value in them? So I know this slide is a little bit hard to see, but this is data from the pilot that allows us to make a couple of different inferences about how it's going to be useful. This is data from Wisconsin showing that over the 2 years of implementation, that their teaching cases, their teaching assistant cases increased from the 71st percentile to the 91st percentile, and then finally to the 94th percentile. And the program felt like this was at least in part attributable to the use of EPAs and its impact on faculty and residents' perception of appropriate entrustment. I can imagine that a resident could come up to an attending that they haven't worked with in a long time and say, hey, look, I've been deemed practice ready in the gallbladder EPA for at least by 5 of your colleagues. And maybe that would allow the attending to have a little bit more trust with that resident, even if they haven't worked with them recently, to allow that resident continued growth and continued autonomy in that case. So the hope is that the EPAs will provide a method of growth of increasing autonomy over time. Perhaps of even greater importance is that the Wisconsin data suggested that the anchored nature of those assessments helped mitigate gender bias in faculty assessments. Their study found that when faculty focus on these observable behaviors like EPAs, their evaluations are not impacted by resident gender. This study also interestingly compared self-assessments, female and male self-assessments during the same time frame. It was interesting that the study found that female trainees rated themselves as lower than their male colleagues. And in narrative part of self-assessments, the female trainees focused on words like guidance and supervision, whereas the male trainees focused on words like independence. And finally, the American Board of Surgery believes that the EPA, as a structure for providing frequent microassessments that are captured in a timely way, will provide some efficiencies. Maybe we'll be able to eliminate the vast majority of the part of the end of rotation evaluations, which currently have all of the milestones for every single rotation. As the IT system improves, we hope that the data integration will allow some automated functions. Maybe we'll be able to automate integration with the case logs that residents are putting, milestone maps, and also faculty development. So how is this data going to be used? So data is going to, as I said before, data is going to be used, is securely held by the Simple Collaborative. The data is intended to provide frequent formative assessments for the residents to know what level of entrustment they are at and what level of competence they are at. And again, the dashboards will be customized to residents, faculty, and program directors and CCCs. Currently, the app that is out right now does not have a ton of dashboards for us to see. It is sort of like building the plane as they're flying it, so to speak, but I anticipate over the next year or so that these customized dashboards will become a reality. The ABS's stated goal for the first year is progressive engagement. So not meaning that year one, we're going to have all residents, every faculty doing this all the time. It's actual just progressive engagement. In a summary of the EPAs will be required for the class of 2028 when they are putting in their application for their qualifying exam. And the goal at the outset would be, of course, to have all graduates demonstrate practice-ready performance in all of the 18 EPAs. But that honestly remains to be seen if that's really going to be what the ABS requires. And that ABS is going to make those decisions based on the data collected across the US. And the exact numbers will be determined again with time. So how many EPAs at practice ready does a resident need to be considered ready for graduation? That is still TBD. But if you think about it, if an attending filled out, if a resident had 2 assessments filled out every week, and over a 6-month period of time, that's about 50 assessments. And if all those 50 assessments were available for CCC discussions, that would be about 45 more assessments than we have right now. So you can see that the more small data points that we have, the clearer the picture that the CCC will have to see how a resident is actually doing. And if over time, if this rate kept up, we'd have 500 micro assessments over the course of a 5-year training program. So the question is often asked, like, how will our system handle the competency model for those who require more or less time to be practice ready? That's obviously a question with a larger system discussion. But in the meantime, the system could create some flexibilities for residents who meet the competencies before completion of training. And maybe those particular trainees could be then certified to do evaluations on junior residents, or maybe they're given a sense of they're given autonomy in cases where they were not previously. Another question that comes up is that, can residents complete EPAs on more junior residents? And in general, the ABS says that they don't want residents to be a substitute for faculty in completing the EPAs. But in some cases, and I personally believe that this will happen over time, as chief residents who've participated in EPA training and have reached the highest stages of entrustment, I think they will be given the opportunity to complete EPAs on junior residents. So how's it looking at CU? We started enrolling our faculty and our 1st and 2nd year residents in July this year, a few months ago. 131 residents and faculty have the app on their phones. Our top performing faculty has been Dr. John Moore from the VA, who's completed 8 EPAs. And our top performing resident so far has been Dr. Lavanya Swaran, who's completed 4 EPAs. However, more than 90% of people who are enrolled in this have completed none. So, to be honest, it's not a bad place to be. There's only one way to go, one way up. So I'm just going to go through a few slides for faculty, how to do it. And I don't have a set of slides for residents. I'm hoping Dr. Lavanya Iswaran will be my resident champion soon, if she's listening. So I hope you can see this a little bit. So first thing the faculty needs to do is obviously just open the app, right? Pick a resident from a list that's already pre-populated. Choose an EPA. And you can see that the EPAs are separated by the phase of care, intraoperative, post-op, or pre-op. After you do those 3 steps, just confirm your choices. Save it. And then pick the level of complexity. How complex was the patient that you're dealing with? that moment. Straightforward, moderate, or complex. And then choose the level of entrustment that you as the faculty would give to the resident next time based on what you witnessed today. Again, that's limited participation, direct supervision, indirect supervision, or practice ready. So one of those four, a level of entrustment. So choose that level of supervision. And then if you have the opportunity to take a few minutes to dictate your feedback, like use both hands, or you did great with XYZ, or work on, ABC. I think that particular part of the app is particularly useful for our trainees, and they crave that immediate feedback that will help them improve for the next case. Yeah.
I think that was probably typically the resident had initiated it, but now it's like it can be either side.
Either side can initiate it, residents or faculty. Right now, you can just put in the scenario. Correct me if I'm wrong for the super users who have been working on this on a daily basis. Yeah.
So that makes it a little easier.
Right, and residents and faculty can initiate.
It's obviously a clinical scenario that in the OR it's obvious because it's linked to a type of case, but I'm thinking about something like a consult.
So I would recommend filling out one of these EPAs within a day or two of actually doing whatever it is.
Sure. Yeah.
So not waiting till the end of the week to say, all right, what happened this week? Let me fill out my 10 EPAs. So trying to make it a habit for in the moment assessment is actually what makes this most effective.
I guess if you're an R2 on tax and you're seeing a bunch of consults and you get these feedback, there'd have to be something in the notes about like, this is this patient. Otherwise, you're not going to, I mean, you might know that you're doing a good job, but you're not exactly sure what patient encounter that's linked to. Is that correct?
Yes, unless you put more detail in there, the resident might not know, but I suspect if you're doing it within a day or two of the particular event, that would be pretty obvious.
It depends on how busy the service is, but yeah.
I do think it can go both ways, but we're right. The younger generation, we trust them to be able to lead us older folks through technology a bit more. So if you want to learn more about EPAs, and I'm wrapping up here, you can go to the American Board of Surgery website, and they have EPAs on their top banner. And you'll be able to click on a variety of links with FAQs, upcoming events, schedules, publications, timelines, and etc. And this talk was put together by ideas and leadership by these various folks here, along with a long list of volunteers whose names are posted on the ABS website. I've posted here some QR codes if you want to go directly to the ABS homepage, or if you haven't seen the app or you don't have the app and you want to see a demo, there's a QR code for that. So thank you for the opportunity to present, and happy to take questions.
Thank you, Dr. Jaiswal, for that very informative talk and a view of the future, really. This is being adopted by most of the training organizations as it relates to medicine, not just surgery. So I'll start off with a question and have all of you also think about this. What do you do in terms of logistics? Let's say this advances and some people are ready to move through general surgery residency in 4 years, and others may take 6 or 7 years. How do you keep Dr. Naylor saying in terms of figuring out the schedule for 92 general surgery residents. Or it may be, I'm not going to say it's easy, but it may be more practical for somebody like Dr. Meacham, who has 15 urology residents. That, maybe you could be the airport control tower a little bit easier. But even then, I imagine that it would be very difficult to organize people coming in and coming out when there's variability.
No, I totally agree. And I mean, Dr. Naylor already acts as air traffic control for all of our research residents coming in and out. And this would just add another layer of complexity to that. How that actually plays out in the end, the American Board of Surgery, it honestly is TBD. They have not been able to say like, okay, if they don't, how many EPAs does a resident need to meet at practice ready level in order to be considered okay to graduate? That data is just not there yet. And then over the next few years, they hope to collect that data to make those decisions. Even the Canadian folks who are at least 5 years ahead of us have not yet made the absolute decision of, okay, somebody's ready to graduate at 4 years.
Yeah. I mean, I think that's going to be a major hurdle, but that doesn't, stop the value of being able to better evaluate our surgical trainees.
Yeah. One of the best parts of the APDS meeting every year is their visiting lecturer. And 1 year they had some PhD psychologist who gave a talk and said that we train like we brew tea. So if you put the tea in the water for a certain minute, you get this tea and then that tea, but we don't really have any flexibility. I do feel like we have been able to flex at the senior level of trainees, and we've done so in the past, where, sometimes we graduate 11, sometimes 10, things like that. I think at the junior level, it's much more difficult. And the hospital doesn't think of it that way. They're like, we pay a salary, where's our resident at whatever our level? And so it would require a quantum shift. I also thought your distribution slide was very interesting because someone who does a lot of clinical trials, it's very similar. So typically a third of the sites recruit 2/3 of the patients in the trial. The other third are recruited by the middle third of sites. And then you've got a third of sites you shouldn't even have open because they don't do anything. And so that's true over and over and over and over. And so if you consider this being a clinical trial where you're trying to enroll, in this case, feedback rather than patients, we have to figure out how we can get in that top third, because that's sort of the demographic. And typically in trials, the way you do it is you have multiple meetings, investigator meetings, things like that engage people over and over again because interest wanes. And then you've got to, typically when you have those meetings, then all of a sudden you get a lot more recruitment for a month or two and things like that. And so some of those strategies are probably what we're going to have to employ. And then ultimately, when people talk to me, because typically what happens is when we have an alumni who's going to get a job, I'm like the last person they talk to. Like, I'm just doing my due diligence and I want to make sure there's not anything we've missed and we want to hire this person for whatever. But they might ask me now, what's their EPAs and, what sort of issues do we need to think about as a junior faculty that they have, that's specific to this feedback, so that they can work on it. Because your training doesn't end when you graduate. You're still getting, learning. And so if there's some specific area that needs to be focused on, then a new employer would know those things, and it might be beneficial to the junior faculty who's either starting in community or academic practice.
You want to comment?
Yeah. So I think that's a concern from many of our trainees, like, are future employers going to have access to our EPA data, right? And will that change my employability? So as of right now, the ABS is not at all planning to have that available for public distribution that after graduation. So while that might be okay for a sort of internal within a program kind of evaluation, I think that having it available widely to the public is something that's still far off.
We have several chairs or presidents of boards actually in the audience. I'd be interested in their thoughts.
I'd be happy to ask a quick question. Dr. Jaiswal, this was a really nice presentation. I a number of years ago was chair of the urology RRC when the next accreditation system came through, and there was not, universal embracing of that, but it really was a much better process than we had before. And I think this will be as well. Question for you is, so much of this, really almost all of it, hinges on individual faculty feeling prepared to assess and to provide feedback, which is not necessarily an easy thing to do. I find that when there's something I know I'm supposed to do and I just keep putting it off, it's oftentimes because I just am not comfortable with it. So I kind of move on to stuff that I am. What are your thoughts about how we would go about best preparing our faculty to be able to assess? I mean, I'm thinking of assessment OSCEs. I mean, who knows? And to give feedback. And then how do we close the loop by letting them know what parts of what they did were particularly valuable and what areas they may want to improve on so that our faculty can get better with this as well?
Thank you for that question, Dr. Meacham. I would actually going to ask the audience members who have actually used this EPA and like what helped them get started and what helped them continue to put this into regular practice. I do think that faculty development and resident development are important each year, and especially onboarding new faculty who join us to understand that this is just part of our culture. So, Nicole.
So I think some of the one of the really nice things about EPAs is the language in the actual evaluation itself is really like observable behavior based and focused in a really understandable way. And so if you just read the EPAs that are, specific to your specialty, so it's easy for me. I just search for breast. There's pre-op, intra-op, post-op. And if you actually read all of these levels of the, limited participation, direct supervision versus practice ready, it's a clear suite of behaviors that's really immediately identifiable for you as a faculty member doing it every day. And so a lot of it is just getting used to it. And then I think in terms of implementation, because the goal from the American Board of Surgery this year, like the bar is very low. They're looking for progressive engagement, which means that if you're one of those two programs that did 0 evaluations in their pilot, if you did 1 evaluation, the American Board of Surgery is going to be patting the program on the back saying good job for progressive engagement. And so for me, what I found to be the most helpful is I just try to do 1 a day. I just make it a part of my thing. It takes literally 20 seconds. You have the same resident on your service. So your recently evaluated residents are at the top of your assessment. So, I just hit the same resident, tell them I'm evaluating them on X case or patient from clinic or rounding that day. And then I fill it out and then I'm done. And so 1 a day, and then right 1 a day, that means that I'm doing 5 a week for any individual resident.
Yeah. And, I think most attendings are like me. I constantly give feedback. Anyone who's operated with me knows I give constant, I'm tired at the end of the case, not from operating, but from, saying, do this, don't do that. Oh no. I do the same, when we round or talk about patients, but I'm not good actually at getting things down on paper or in electronic format. And that's something I will have to change. Piyush, you are in charge of my success in doing a simple or 2 before the end of your rotation. Okay, so you're going to have to study up and teach me how to do it. And I think every other attending needs to make the same commitment.
I'm going to just veer off slightly because I think this is, for having done.
Use the mic. Use the mic.
Can you use the mic?
All right. All right. I think this is much needed from having done evaluations for 30+ years. I think this is a good direction, but what really caught my attention was your slide about bias. And how does the American Board of Surgery think that they're going to change bias when you have your women who feel like they are 1 level below men who think they're totally competent? Do they think that just looking at these evaluations is going to change their biases?
Yeah, that's a good question. So that data that I showed was what male and female trainees self-assess as. So when the faculty assess the trainees, there isn't any difference between male and female trainees. So it is actually that thought process that women, for whatever reason, tend to downplay how good they are. And I do think seeing data like that can help female trainees to realize, yeah, I'm much better than I thought.
So I just want to clarify one thing. You're right. Nobody ever looks at any of the evaluations or anything like that when the residents are graduated. I mean, the conversations I have with a future person who's the division head who's going to hire somebody is just very conversational. And they basically want to know, what do I think about the person in general? And I would say that in my experience, we have a lot of alumni that 90%, if not more, of anybody struggling after graduation is behavioral and how you get along with people, not how you take care of things and how you can operate in your skill set. So those sorts of things, if anybody was to have any trouble, those tend to be much more likely the issue and not somebody's competence, in my experience. Fortunately, it's very small that happens too, but those are the most common things. And, we have a very good reputation of our graduate. I've heard multiple times from other faculty that tell me, I know people from Colorado know how to operate, and then ... but that's not the same for a lot of famous programs ... And so we have a reputation of putting people out who know how to take care of patients and know how to operate. And so that is our national reputation. But this is sort of like proving it with data and feedback, and also doing a much more intentional approach of trying to navigate the trainee through their journey so that okay, this is a specific thing that you need to work on, and here's some information that helps you.
I mean, I think the main value, at least initially, will be more data points for the training, right? And I think that's good. Last comment, Piyush.
I think this is a very good job of measuring the input of knowledge and skills that are imparted, but I haven't got any research that measures the export that's happening. Just as there's variability in trainees in terms of their level of competence, there's also variability in how much they're allowed, or the arena they're provided with, within which to display their performance. So is there anything built in wherein the attending, or wherein the resident can say, well, hey, I wasn't allowed the autonomy that my evaluation is alluding to. So for example, if in a colectomy, all I did was hold the camera, they don't really have any validity in wherein they say anything about dissection. So is there a comment that while the resident initiates the evaluation, they can make a comment like that?
So I think the more data points the resident has, like the more EPAs that have been filled out on your colon EPA, for example, that says Piyush is, getting the indirect supervision, or has 5 practice ready assessments that different attendings have said Piyush is ready, practice ready for this, colon EPA. And so I think you could pull up that graph of, hey, look, these are my 5 different assessments that I've had from other faculty members. What do you think about letting me do XYZ on this case too?
I think we should one short comment or question and then end it. Dr. Naylor.
So I think that sort of information is available if you see a certain attending where all of the evaluations are the resident was mostly an observer, and it doesn't matter which resident, it's consistent, and other attendings doing similar things, there's a lot more participation. That tells you as a program director that, that person's not letting people do as much. Now, maybe it's complexity, or maybe it's just not letting them do enough, and allows you to target it. But the only way to do that is you have to have huge amounts of data so that you can actually look through and see and compare. But that would be the aspirational thing from the teaching side.
Thank you. All right, 8 o'clock. Everyone have a great week, and thank you.